Hi, I just wanted to introduce myself. So my name is Pooja Lagasetti. I'm one of the Robert Wood Johnson Clinical Scholars and also one of on the board of the IHPI seminar series. And we're incredibly delighted to have Dr. Norton here today with us today. So Dr. Norton joined the faculty at the University of Michigan in 2008 as a professor in both the School of Public Health, Department of Health Management and Policy, and the Department of Economics. He's the director of the RWJ Foundation Scholars and Health and Society Scholars at the University of Michigan and a research affiliate of the Population Studies Center. In addition to his affiliations with the University of Michigan, Professor Norton is a research associate at the National Bureau of Economic Research in the Health Economics program. So before coming to Michigan, he taught at UNC at Chapel Hill and at Harvard Medical School. He's led several studies on the economics of long-term aging and long-term care. He has studied how nursing home reimbursement rates affect quality and cost of care and the extent of adverse selection and the motives in the private long-term care insurance market. In 2003, at UNC at Chapel Hill, he even awarded him the Philip and Ruth Hedelman Prize for Artistic and Scholarly Achievement by young faculty. So we're incredibly excited today to have Dr. Norton, and if you guys could help me welcome him today.
Thank you all for coming today, and I want to say that I think this event has somehow escalated, and there may be some misunderstanding. When I was first approached to speak today, my understanding was that this would be sort of a small, informal seminar, so a little lunch talk. I could talk about some of the ideas, things I did on my sabbatical year last year when I was away and spent half the year in Japan and then another 4 months in London. And then I was going to sort of transition on from research and then maybe show some pictures of our year abroad and tell some stories, like the time that I was nearly arrested for abducting a child in Japan, true story, or the time that I played a concert in Greater London with a community orchestra, and at intermission, half the orchestra got drunk. Again, a true story. So I was going to tell these kinds of stories and many others, but then I heard that lots of famous, serious people were going to be in the audience, and they were going to be expecting serious discussion and real content. So the talk has changed because I know you are all desperately eager to hear me talk for an hour about economics. So that's what I'm going to do. Also, some of you, I'm sure, were attracted by the free lunch or the misunderstanding. I mean, I am not the Hollywood actor, okay? So I just want to make that clear as we get started. So I want to talk about some ideas that I've been thinking about over the last several months in working with others here at IHPI. So this topic, I think, is very appropriate for this audience and very timely and policy relevant. And I want to start by having people think about an episode of care for a Medicare patient. So imagine that a Medicare patient is admitted to the hospital, she's treated, she's discharged, and then there's reimbursement for that hospital visit and the follow-on care afterwards. So there's DRG payments with various adjustments for treatment and teaching and dish payments and so forth, and there are payments to physicians, and there's various post-acute care payments that we'll keep track of. Also, what's important there is 30 days post-discharge for various kinds of post-acute care. And all of these together contribute to the episode cost. And there, I'm sure you're all aware, there's a growing emphasis on thinking about cost of care not only for the index admission to the hospital, but for follow-on care as well, and thinking about the entire episode of care and the quality of care during that entire episode as well as the cost. But what I want to talk about today is another kind of reimbursement, what I think of as a new way of thinking about some additional reimbursement that I think is important And this is due to the various pay-for-performance kinds of plans, in particular the hospital value-based purchasing and the readmission reduction program. And these types of pay-for-performance programs create additional incentives, financial incentives for the hospital and providers to do well on a variety of metrics. And what I will argue today is that that means that every patient has a marginal effect not only on the metrics used to evaluate the hospital performance, but then that marginal effect on the metric translates into a marginal effect on future Medicare reimbursement for that hospital. And I'll walk through a little more of how that works. But I think this is potentially very important for understanding how these pay-for-performance programs work and their incentives and distributional consequences and so forth. So the idea then is we want to think about the total reimbursement for an episode of care as being not only the current episode payment, all the stuff in the first slide, the index admission, the physician payments, the post-acute care, and so forth, but also a future marginal reimbursement that happens after the data are collected and cleaned and massaged and turned into a percentage bonus and then affects future reimbursement roughly 2 years later. And the delta there is a discount factor for the economists in the room. We care about that, adjusting for inflation. But the idea then is total episode payments is not just the index admission plus 30-day post-discharge, but also this marginal future reimbursement where every patient, every Medicare patient, has the potential to influence the scores and therefore the percentage bonus and future Medicare payments. To be clear, a lot of people in the literature so far have looked at something like the percentage bonus that hospitals are getting from one of these pay-for-performance programs. And then each hospital has annual Medicare revenues. You can take that percentage and multiply, and you get a big number in the many thousands or hundreds of thousands of dollars. And that's sort of the overall percentage bonus dollars that the hospital will get. I'm not interested in that number alone, although I think it's quite interesting and there's some real distributional issues there. I'm interested in the derivative of that. I'm interested in the marginal effect of every patient on that and understanding how big it is and the distribution of that and what the incentives are. And I think we can calculate that, and I think we've got a lot of interesting research ahead of us in that area. So I'm going to give a brief summary of the hospital value-based purchasing program. It's incredibly complex. There are many people in the room who know far more about it than I do, and so I want to give an overall summary to get at the basic idea of what that's about, and then give some examples of what I'm calling the marginal future reimbursement, and then talk about some implications of that for incentives and for research, and then I'm going to talk about my research agenda going forward and what I would like to study. And I've got a couple preliminary results to show you sort of what your appetite and try and convince you that this is really an interesting thing to do. And then hopefully there'll be time to take questions and get your ideas as well. So two of the main pay-for-performance programs that Medicare is using, one is the hospital value-based purchasing program. It's currently in its third year. And the idea is to reward good performance on four main areas: good clinical practice, patient health outcomes, including mortality, patient satisfaction with care, as well as low spending. So those are good things we obviously want to encourage hospitals and providers to do, and this is providing some financial incentive to do all of those things. There's also a hospital readmission reduction program which penalizes hospitals when there are at least one readmission for patients for certain conditions. I'm not going to talk as much about that, although the basic ideas that I present here would also translate, I believe, very well to the readmission program as well. Okay, so when I say details about HPBP, what I really mean is very cursory, summary details about this. This could go on and on when we get into the details. This program is incredibly complex in its details and understanding the formulas of how one goes from the original measures about quality and spending and ultimately ends up with a percentage bonus. It's also changing. The rules are changing. Not only the final percentage has been increasing every year of the program, now up to 3%. It is also the case that they've added and changed some of the measures so that more things are being measured, and that this will undoubtedly continue to change in the future. Another thing to point out is that the measures are not for every patient who comes into the hospital. These are for a subset of patients, Medicare in particular, but also certain measures are only measured for certain patients. Mortality, for instance, is only done for 3 conditions. Also, some hospitals don't have enough patients of a particular kind to actually get to register a meaningful score, so there's a certain threshold you have to be over in order to get this, and not every hospital participates, et cetera, et cetera. But anyway, for those patients who are in this, and for hospitals that are participating, I expect that over time, these pay-for-performance programs will continue to be more and more important. They may continue to increase the bonus. Blue Cross Blue Shield of Michigan is adding their own flavor of this. I'll talk about a little bit at the very, very end. So in terms of what is actually measured, there are 4 main domains, 3 of which you could consider more quality related and 1 spending. So there are 12 clinical measures of care for AMI, heart failure, pneumonia, and surgery patients. There are certain very specific measures of whether patients did or did not get certain clinical procedures, for example, prophylactic antibiotic use for certain surgery patients. For patient satisfaction or experience, that's taken from 8 of the hospital CAPS measures. Those tend to be about communication, pain management, whether there was appropriate discharge information provided to the patient, that sort of thing. For outcomes, they've expanded recently. It started with just mortality for 3 conditions, again, AMI, heart failure, pneumonia. This year they've added 2 others, some patient safety indicators for things like sepsis rates and ulcers and various other things, as well as central line associated bloodstream infection for ICU patients. So again, a number of very specific clinical outcomes that can be measured fairly easily that are clearly associated with quality. And finally, episode spending, where episode in this case is defined not only as the index admission and 30 days post-discharge, but also the 3 days prior to index admission. So all these measures are collected from claims data and from other sources, and collected and cleaned, and CMS then takes that and converts it from measures to points to a total performance score to a percentage bonus, and then finally that translates a couple years later into real dollars that affects the bottom line of every hospital that participates. So briefly, this conversion from clinical measures and actual spending, those are converted to points, basically numbers from 0 to 10 or 0 to 9, though with points awarded for each of the domains or subdomains. Then all of those points are taken, there's a weighted average of all those points. That is then turned into a total performance score. And then the total performance score is converted linearly to a percentage bonus, and then the percentage bonus affects future Medicare inpatient reimbursements. Okay? So you can see then that for every patient that comes into a hospital, they can affect all of these measures depending on their experience. That will affect the points, which ultimately affects the total performance score, which affects the bonus, and ultimately dollars. And sort of do that derivative all the way through that equation. Now it's very complex, it's very nonlinear. I'll try and give you a little bit of a flavor of that. But there's not a very simple formula that easily applies here. So we're going to have to do some real work to figure out what these numbers actually are. And it's not at all clear at this point whether these marginal future reimbursements are really big or really small. Okay? But hopefully you can see that every patient would affect the measures, and that would eventually translate to dollars somehow. Whether it's large or small, we don't know yet. Okay. A little more detail on going from the actual measures to points. And this, I think, is where it's most complex, and I'm only going to devote one slide to this, or we'll get completely bogged down. Partly the points depend not only on how that hospital does, but how its performance does compared to the distribution of other hospitals' performances, as well as how that hospital does compared to its baseline rate from around 2011. Okay? And so one way to say this is that hospitals can either get points for doing well on an absolute scale, achievement points, or they can do well by improving. If they start from not such a great place, they can improve. So CMS wanted to reward both those who were doing well on an absolute scale, for whom it's really hard to improve if you're already at the top. And they also wanted to reward improvement so that hospitals wouldn't say, well, we're nowhere near the very, very best on this particular measure, why bother to improve? So you can win points either for achievement or for improvement on an absolute or on a relative scale. Basically these points are awarded for both, and then you look at the 2 points and you take the better of the two. Okay? So to get some sense of how this works, you look at the distribution of results for the hospitals, and you look at your own hospital's performance, and if you are in roughly the top 5%, then you get the top score. Technically, it's the mean of the top decile, but that's going to be around the top 4 or 5%. You get the top score. If you're below the median, then you get 0 points. And if you're in the roughly 45% of the upper middle class, then it's on a sliding scale. Okay, and you get from 0 to 9 or 10 points. That's roughly the way it works. So again, it depends on the hospital's performance relative to other hospitals or their own performance. You can gain points for either doing well on an absolute or a relative basis. So once all these points are awarded for the various different domains, those are then weighted and added up to give a total performance score. You can see the breakdown here with slightly more weight given to patient satisfaction and the outcomes, including mortality, at around 30%. A little less for the clinical measures and what CMS calls efficiency. I do not like that term, but that has to do with episode spending, and that's new this year. So that adds up to 100%. So you get total performance scores, and then that is linearly converted into a percent bonus up to 3%. Okay? And you want a higher performance score because that translates into a higher percent bonus and higher payments in the future. Okay. In terms of the timing, we are currently in fiscal year 2015, which started just under a year ago. Obviously, the federal fiscal year starts on October 1st. Most of the baseline measures were taken in 2011, and the performance periods that this fiscal year's bonuses depend on largely come from 2013. It turns out every single measure has its own little timing. It's not exactly a calendar year, but it's roughly 2013. And therefore, it's roughly a 2-year lag from when a patient is admitted to the hospital and has their experience to when its marginal future reimbursement actually takes effect and would affect the bottom line of that hospital. Okay, so as an example, imagine what you might call a good patient from a hospital's point of view in terms of HPBP reimbursement. She receives clinically appropriate care. She has a good experience. There's great communication. She gets all the information she needs upon discharge. She is happy. She spends relatively little, especially on post-acute care, is not readmitted, at least not within 30 days, and she lives. That's a good thing, right? So for all of these things that happen to her, these are all high quality, low spending, all of that. All of the hospital's HPBP scores improve, at least slightly, right? Unless a hospital does that for every patient, in which case we need to clone the hospital, but that's rare. So that's the good patient, and of course the bad patient is just the opposite. He comes in, he does not always receive clinically appropriate care. He has a bad experience, unhappy, he fills out the CAPS form, does not have good communication, spends a lot, particularly on post-acute care, is readmitted a lot of SNF care, and dies, has the indignity to die at the end. So that obviously all worsens the hospital score, and that's bad, okay? So you can then imagine how each of these patients, or various combinations of different parts of the patient, would affect different parts of these scores. Of course, if they're not an AMI, heart failure, or pneumonia patient, then they wouldn't be able to affect some of the outcome scores. But each patient will affect these HPBP scores in some way, and that will affect the future Medicare payments. So again, thinking of a marginal patient, if that patient did or did not exist, if they did or did not actually go to the hospital, we can, in theory, calculate how the scores through the total performance score through the percent bonus would change if that patient had or had not been admitted. And we can calculate each part of the change in each part of that sequence of scores all the way down to the change in the hospital's future Medicare reimbursement, okay? All right, so that's the idea here. Some of this is easier than others, as I will point out. And then after about 2 years after the index admission, so that patient's experience will affect the actual reimbursement for all Medicare patients admitted to the same hospital. So even a potentially small change in the percentage bonus multiplied by the average reimbursement for an index admission summed up over all Medicare patients for a year, that could be a big number, particularly for a hospital like University of Michigan, which has a lot of patients, a lot of Medicare patients. That could result in a very large marginal future reimbursement. Although we don't know yet how big that is. So I now want to talk about some implications. And this first slide should be blindingly obvious for anyone who's thought about this at all. There's really nothing new here. This really comes directly from the motivation for the Pay for Performance program, that the marginal future reimbursement really depends on the actual outcomes and quality, because that's what these programs are designed to do. It's no longer just about quantity. The more you do, the more you get paid. It's actually about real outcomes and doing a high quality job for relatively modest amount of money. And also, the point of this was to provide incentives not only to the index admission, but for the entire episode of care, so that hospitals would start to think a little more broadly about the care they provide over a slightly longer period of time. Okay, so we knew that already. But let me talk about a few other things. One is, this is really complicated. So back when I was, well, younger, and DRGs came into existence, you know, we would think about Medicare payments for hospital care as being the DRG. And then gradually we realized that, well, there's actually a lot of variation even for patients who have the same medical condition. There are differences of treatment of what they get. There are differences in Part B payments and consults. And then we've recently expanded our view to think about the entire episode of care, say out to 30 days post-discharge, and thinking of the entire episode of care, including any readmissions that can add on to the cost of care, because post-acute care is quite expensive on average. But in addition to all that, I'm arguing that each patient also affects future hospital revenues in this way, and that adds sort of just another whole layer of complication to this whole equation. Another implication is this could be positive or it could be negative, right? We think of revenues and reimbursement and payments as always being positive. You never get a negative amount of money. But in this case, it actually could be negative, right? Think of the bad patient. All those terrible things happen. All the measures get worse. That will lower all the scores and lower the percent bonus. And so relative to that patient not actually going to the hospital, the patient could actually cause negative total reimbursement for their episode of care if you take into account their future reimbursement. Could be. There's going to be a distribution, okay? But that's at least theoretically possible. Another implication is heterogeneity, okay? It's no longer the case that every patient who comes in with an AMI or has a certain treatment, DRG, gets basically the same payment. There's going to be tremendous heterogeneity in these future Medicare reimbursements because of the variety of ways that patients are scored on these different quality and spending outcomes. And also, of course, it's only for Medicare patients, and it's more things are scored for patients with certain clinical conditions. But there's tremendous heterogeneity in these marginal future reimbursements within hospital, as well as there being tremendous heterogeneity across hospitals in the distribution of these things. So we expect to find very different marginal future reimbursements across hospitals for a variety of reasons. Certainly, hospitals have very different mixes of patients. If you have very few Medicare patients, then you're not going to get much future reimbursement, and whatever the percent bonus is, you're not going to affect a large number of dollars because you have few patients. Hospitals also have very different baseline levels of care, and it's certainly possible to have zero effect on the score depending on where the hospital is in the distribution. Some of the patients will have, even with a bad experience, will have zero marginal effect on some of their outcomes on the reimbursement simply because of where the hospital is in their distribution. Whereas if they had gone to a different hospital, they would have a much larger effect. And all these things are nonlinear. But we expect to have very different means and distributions across hospitals and within hospitals because of these different heterogeneity. And that leads to, therefore, very different incentives that the hospitals have. Now, on the one hand, hospitals, hopefully, have always cared about quality and keeping costs down, or at least high quality, and without these pay-for-performance programs, okay? So clearly there are professional norms and standards that encourage high quality of care. On the other hand, these programs were created specifically to give financial incentives to do a better job on quality and spending. And if they are successful in creating appropriate incentives, then hospitals should respond to them, right? So I think it's important that we find out what these marginal incentives are and see whether hospitals actually respond. For example, the return on investment to, say, trying to reduce readmissions or improve patient satisfaction scores or lower mortality, those will differ across hospitals because of these marginal future reimbursements, will differ a lot. Some hospitals really should focus more on one thing, and other hospitals should focus on another, at least from a pure financial point of view and how they do on these pay-for-performance programs. Another implication that I think is a little more subtle is that there are very interesting trade-offs within this. So again, looking at the big picture, with the HPBP program, we have 4 different domains: clinical quality, patient satisfaction, patient outcomes, and then spending. And that means that there are multiple ways that one can improve the percent bonus, right? You can improve your percent bonus by doing better, by lowering mortality, or by lowering spending, or by improving adherence to the clinical measures, okay? And therefore, there are different trade-offs between achieving the same goal of improving the percent bonus, but there are different ways you can trade off ways to get there. So hospitals, therefore, implicit in these formulas are trade-offs between quality of care versus low cost, and we can actually estimate what those are, and I'll show you some numbers at the end. Okay, given those implications, I now have come up with a research agenda for this area, starting with just the distribution. So I claim that marginal future reimbursement is an interesting thing, that it affects incentives and so forth. How big is it? Okay, I don't know yet. I'll give you a little bit of a number later with some caveats. But it matters greatly whether these are really small or really big or somewhere in between. And it matters not only what the means are, but also what the distributions are, and how these differ across the different domains and across different hospitals: teaching versus non-teaching, urban versus rural, hospitals that treat predominantly different kinds of populations. And that will be really interesting to figure out, and I don't have those numbers yet, but that's sort of where I need to start, is looking at summary statistics and looking at the correlations with different kinds of hospitals and looking within hospitals and seeing how they vary and across the different domains. After that, I think the next thing will be really interesting to look at are the incentives. How big are they? And how do hospitals respond to these financial incentives? And in particular, how do hospitals in different parts of the distribution of where you are relative to your peers, how do they respond to these financial incentives? Do hospitals that are at the low end just sort of give up and say, look, this is clearly not our comparative advantage to keep patients from dying in the hospital, we'll just kind of give up and focus on other things? Or do these incentives apply sort of throughout the distribution, and do they respond to them in similar ways? That will be very interesting to look at. Also, because these rules seem to change every year, how do those affect marginal future reimbursement as the percentage increase changes, as the weights between the different domains perhaps may change in the future, as they broaden it to more conditions? How do hospitals respond to that? And then I also want to look very much at these trade-offs. For example, what's the value of reducing 30-day mortality? We can actually estimate that, and I'll show you a number. So over the next couple of slides, think of what you would be willing to pay to reduce 30-day mortality by 1. Okay? What's the value of reducing mortality, preventing one death in a 30-day window? In addition, we'll be able to look at the implicit trade-offs between, say, clinical processes of care and patient satisfaction, or any of these different things. They are implicit in the formulas. And finally, I think there's sort of a broader general view here of what's the value of all this information. We are entering the era of big data. We have a lot more information about patients at a very granular level. what do hospitals want to know? How will they use that information? I see this sort of as akin for baseball fans out there as the sabermetrics revolution, and understanding that things like wins for a pitcher or batting average are not that meaningful, and they're much better measures. And so instead of wins above replacement, we can think dollars above replacement patient or something like that. And in terms of thinking about how each patient affects hospitals' bottom line through their effect on these outcomes. So I think that'll be very interesting over the next several years to understand how hospitals use information, if we can actually take the data in a timely way and present it to hospitals. Would they want to use this data? Okay. I always like to start with thinking about what the ideal data set is. And if I had unlimited resources, what information would I want to be able to do the research I wanted to do? And in this case, I'd want, well, everything. I'd want all Medicare data at the patient level. I'd want to know all of the patient-level clinical and health outcomes that's not in the claims data at the patient level. I'd want to know all the risk-adjusted, price-adjusted reimbursement at the patient level. I'd want to know the HCAP scores. I'd want to know everything, and we don't have that. But we do have a lot. And making some modest assumptions, we actually can do an incredible amount. We have a lot on the price and risk-adjusted reimbursement. We know a moderate amount about some of the health outcomes at the hospital level, and we can do some things to sort of back out some very good guesses as to what these marginal future reimbursements are. So let me give one example, mortality, okay? So as a reminder, for 3 conditions, AMI, heart failure, and pneumonia, the mortality rate, 30-day mortality rate, is kept track of for each hospital and compared, and you get points and so forth. We don't know exactly which patients died and which did not, but we do know each hospital's mortality rate. And because it's binary, that gives us a lot of information. And we know the denominator, that's the total number of patients over whom the mortality rate was computed. We know the baseline and threshold values. And so it's actually fairly easy to do the following, which is to say if that hospital had one fewer mortality during their time period, how would that affect their mortality rate? How would that affect their points, their total performance score, the percent bonus, and so forth? Okay, so we can back out actually a reduction in mortality of 1 for each hospital, and then average that. And Anoop Das did some great work yesterday to help me figure this out. Now these are preliminary results, and I need to provide some context here. But numbers are, you may think, kind of small. Okay, so this is marginal future. This is the amount of money that the hospital would gain back by reducing mortality rates for these 3 conditions about 2 years later, summed over all the patients. We made some mildly heroic assumptions about certain average number of patients and so forth, but this should be fairly close. A couple things to remember. This is each of these are only 6% of the entire HPBP package. So it's pretty easy to imagine that if you sort of scale this up, that the total marginal future reimbursement would be on the order of several $1,000s if you multiply those numbers by something like 16 or 17. Also, just to keep in mind, these results are just for certain patients. They're about mortality. And we only computed this for those hospitals in the upper half or so of the distribution. We ignored the improvement point, so this is probably a little bit of an underestimate. Having said all that, this gives me at least some numbers that argue that these numbers are not 0, They're modestly big, and I think once we put all of the numbers together from the many different domains, we'll find that these numbers are probably in the thousands. What I don't have yet is any sense of the distribution, and clearly that matters. And whether it goes from sort of negative to tens of thousands, I don't know yet. But anyway, that's one set of very preliminary results. Another thing that I know we'll be able to do is look at the marginal effect on spending, the so-called efficiency measure. Because we have access to Medicare claims data and pretty good understanding of who is and who is not included in the measures for the MSPB, that's the Medicare spending per beneficiary, we can approximate the effect of adding or subtracting any patient on the distribution, on the mean of spending, and then we can look and see how every patient affects that particular score and so forth through the percent bonus, and then look at the distribution within hospitals and across hospitals. We have not done that yet, but we certainly have the ability to do that. Then another thing I want to do is compute some of these marginal incentives and look and see at a hospital level where they're most likely to be able to have the biggest influence on their marginal payments for the future year, and then see if they actually respond in that way. We would expect that the biggest incentives, probably if you're in the upper middle part of the distribution, clearly if you treat more Medicare patients, and so basically we want to look and see whether the change in performance year to year, say from fiscal year 15 to 16, is a function of the marginal incentives that each particular hospital faces. You'd expect that they would respond at least somewhat to these financial incentives. If not, why are we doing this program? Okay. Another thing I wanted to show you was some early results on the implicit value of lower mortality. This is, let me point out, this is a different number than what I just showed you, which was in the few hundreds. The few hundreds was what is the benefit, how much money does a hospital get by preventing one death in the 30-day window? So that's a payment. This is about actually, because it has to do with trade-offs, this is about the implicit value, essentially to society, of lowering mortality in general. Okay? So again, there's several ways to increase the percent bonus. Hospitals can improve on various quality measures or on the spending. And so that leads to different trade-offs. And so as an applied economist, you can run regressions to show what these average trade-offs are. So if you regress the percent bonus, which we know for every hospital, on the raw quality and cost metrics, you can run this is a very simplified version of what we ran, but you run a regression of percent bonus on measure of mortality and the measure of spending. And then if you take the ratio of the coefficients, that gives you the dollars per avoided death. Take a minute and think about what you think that number is, or should be. Okay? What's interesting about this is I'm sure nobody in Washington thought about this explicitly, okay? And it's certainly not a number that's in the Federal Register, okay? But given the program, given how hospitals behave, this number is implicit in the whole program, okay? Okay, I want you to think of a number, sort of what's the value of lowering mortality, hospital mortality among Medicare patients, specifically AMI, heart failure, and pneumonia, okay? How much would you pay for that? Not how much should a hospital be awarded for that, that's a different question, but so what's the value of reducing mortality? Now I'm going to give you some numbers that are sort of in a related literature, but they're a little misleading because they are not directly comparable to this, okay? economists for years and years and years have been interested in the value of a human life, specifically a statistical life, and these numbers tend to be computed by looking at things like dollars spent to reduce risk of something happening, okay? And there are a variety of ways to do it, looking at actual behavior surveys or so forth. But over time, there's a general consensus of what the value of a statistical life is. And currently, it's on the order of $9 million, okay? That's for over a whole lifetime. There's a similar related literature looking at value of a life year, or specifically a quality-adjusted life year, a life year in perfect health. That's a much more modest number because it's only 1 year and not many years, and that's more on the order of 100,000, although the estimates actually vary considerably from well below that to well above that, but it's going to be on the order of 6 digits, okay? Low 6 digits. So given that, the numbers I'm going to show you are not either a QALY or the value of a statistical life, but it's the value of reducing mortality in the hospital. And these are taken directly from regressions of real data, so although they're preliminary, these are probably pretty close. So they're on the order of $160,000 to $200,000, okay? I think that's pretty interesting. And want to push that further and refine those numbers and make sure they hold up. But also we can look at other trade-offs within the HPBP program. Okay, so just as we ran that regression, looked at mortality and spending and the ratio of those coefficients, we could look at dollars per avoided sepsis, or dollars per patient satisfaction score, or we could look at trade-offs between, say, clinical quality and patient satisfaction. Okay, all of those are implicit in the formula, and I think would be interesting to understand how those incentives work, and also look and see if it's same across all hospitals or if there are big differences. That could be a little too interesting, perhaps. So this has all been about Medicare and Medicare patients and the national pay-for-performance programs. I want to end by coming down a little closer to home to Michigan. The Michigan Value Collaborative is one of many collaboratives. The others are all about quality, sponsored by Blue Cross Blue Shield of Michigan. And the MVC, the Michigan Value Collaborative, focuses really on episode spending and understanding the distribution across hospitals of who's spending a lot or not so much, price and risk adjusted, and understanding how we can get high quality of care for a reasonable cost. So hospitals can look at their own episode spending and compare it to others and try and understand what they're doing. And so my question to those of you who are related to MVC is, or those who are in hospital administration, is whether, if we could calculate marginal future reimbursement for individual patients and sum those up somehow, would that be useful information? Is this something that we should think about for MVC? Also, Blue Cross Blue Shield will be eventually unveiling a new pay-for-performance metric, including spending. I don't know what that's going to look like, but that also will have various incentives buried in it. Hopefully they're complementary to what's already there at the national level. Now, finally, this is a picture I took. I couldn't resist ignoring my sabbatical year. This is a picture I took in Japan from the top of the Civic Center in early November last year when the sun set around, that's Mount Fuji here, okay? You can see Mount Fuji on a clear day from Tokyo. It's about 150 miles away. It's a gorgeous sunset. The buildings in the foreground here are Shinjuku. We had a great year. That's my talk. I've left some time for audience participation, questions, ideas, thoughts, reactions to what I've said. And if you could tell me who you are so we all
Kevin
know.
Chalmers Surgery. That's absolutely spectacular presentation. And can you comment on the effect of these changes on safety net hospitals? After all, these hospitals are, as you say, hopefully not ready to give up, but they serve a distinct population in San Francisco General, a Grady Memorial Hospital. And with these incentives the way they are, it's probably not enough to offset some of the investment they need to put in to satisfy some of the metrics.
Exactly. And as I'm sure you're well aware, there's already a literature that's looked at that sort of issue for these programs at sort of a bigger level, trying to understand the distributional consequences. And is it the case that hospitals that disproportionately serve minority populations, say, are they getting lower bonus? Are they being penalized financially? And that's certainly part of what I want to look at with the distribution across hospitals. And I just don't know, but that is very important to look at, as well as patients within hospital. So we don't have numbers yet, but that is extremely important.
Hi, I'm Susan Gould. I'm attending a meeting in a couple of weeks with a bunch of researchers who are interested in physicians' incentives, pay for performance type of stuff. And the topic for that meeting actually is the difference and future research on extrinsic versus intrinsic motivation. Based on the literature in psychology, which says that turns out if you provide a lot of extrinsic motivation, that is financial rewards or whatever, you may actually decrease intrinsic motivation for certain behaviors. That certainly resonates with me as a doctor. Of course, doctors are working in their hospitals, so if they're influenced by these incentives from Medicare, that may come into play. But I wonder also whether that would apply in organizational psychology and whether extrinsic motivations might affect also intrinsic ones. Like your opinion on that?
That's a great point. As an economist, we tend not to think that way.
Well, I know that.
But I've learned over the years that economists are blind in certain very important areas, okay? And that sort of psychology is one. And the importance, well, sort of broadly speaking, what's now called behavioral economics, which is really just co-opting what a lot of other people have been worried about for many years. I have no doubt that that is probably extremely important for doctors, for nurses, for clinicians, for administrators, for hospitals as a whole. And I think that's a different line of research. What I can measure, what I sort of am trained to do is looking more at the financial incentives and sort of to first order, are people responding to those? Which is not to say that the intrinsic are not important, but I think those would be harder to measure. Yeah. John?
Hi, Edward. It's John Anyan. Great presentation. One question I have is, what level of detailed information is Medicare feeding back to the hospitals? In other words, they obviously know what bonus they're getting. Are they taking it down? If you sort of work backwards across your sort of flow diagram of how the bonus is calculated, are they providing them with information on all the individual measures that they can then sort of act on, or is it up to the hospitals to calculate what they think their observed mortality or sepsis or satisfaction rates are?
Yeah, so, well, I don't know exactly what the hospitals get. I know we have numbers at the hospital level on all the different measures, as well as the critical threshold points. I don't know exactly what the hospitals are getting for information.
I just wonder if there's a role for some more mixed methods, and we're starting to talk about this more within IHPI. In addition to looking at sort of the national data, summarized for hospitals, looking at, sort of reaching out to, a sample of representative hospitals to sort of speak to the executive, following on Susan's point, speak to the leaders of the hospital, the clinical leaders and financial leaders, to understand how they're reacting, to then inform how we interpret some of the broader analyses that you're in the midst of.
I mean, I think they get this is David Miller, and great talk, Evan. I mean, they get the data on how they perform on each of the domains. And one of the challenges is kind of taking that to the next level because, at least for the Medicare spending per beneficiary, you can see, for instance, that you get it down to the MSDRG level, you can see that you're expensive for urinary conditions, but then you can't see what happens at the patient level. And I think that, at least on some of the high-cost episodes, hospitals want that information, but it's a little difficult to access on the Medicare side, and that's one of the things with the Blue Cross data and MVC is it's a little bit, you can go a little bit deeper to actually see the story of the patient, but it's a good point.
On here. Hi, Edward. Nice talk. So I wanted to just raise a couple issues. Number one, when you talked about the bad patient at the beginning, if that patient dies within 30 days, I'm pretty confident that they are excluded from the denominators for all those other measures. For instance, they're not going to be surveyed about their patient experience once they're dead. So, for instance, you won't have that like double, triple, quadruple whammy thing going on. Thinking about the hospital financial incentives here are very interesting. And I know a lot of people talk about this, but haven't really, I think, made a whole lot of progress towards it. Is that hospitals are, I think, really, instead of like maximizing revenue, it's really about margin. And so, even for like a readmission, there's a lot of question about how much a readmission actually like bites into a hospital. If there's another readmission for like low margin condition like heart failure and pneumonia, yeah, that could be a bite even at that time, but also in the future. But if a heart failure patient is readmitted and has some high margin service, it might ultimately be profitable for the hospital. So I think you talked a little bit about ROI, but it was really from the kind of revenue perspective, and I just wanted to kind of note that complexity. One other thing is about thinking about the magnitude of these effects, and some work that I've done about this in just the first year of the program suggests that the ultimate revenue implications have been really very small. And in dollar terms, we're talking about like an interquartile range of something like less than 50,000 hospitals. And so this is increasing over time, but it's also, I think it has to do with the distribution of the TPS is really kind of peak at around 0. So today you mentioned the relative performance of hospitals it relates, that whole distribution affects the hospital's incentives, but I think we've had kind of a pile up around 0, and as a result we've had really limited impact. So I think that probably my prior is that that affects this marginal future revenue issues given what we know about current distributions.
Let me briefly make a reply to Andy, Ryan, and then it's 1 o'clock and we'll let everybody go. You raised a lot of great points. Yes, it's very complicated, particularly something like readmission where you get additional revenue as well as potentially being penalized. The last point you were making, the relatively low dollars involved. That would be my prior also, is that overall it's relatively small dollars at the moment. I think over time these programs may increase, in particular if Blue Cross Blue Shield's getting involved. These aren't going away in the near future, and I think it is important to understand, to the extent that hospitals are given financial incentives, we should understand what they are, and not only look at the means, but look at the distributions. And I think we'll learn a lot when we see the distribution within hospital as well as across hospital. Thank you very much for coming. I look forward to talking to more of you now or later.